think we'll just go ahead and get started. Good morning, everyone, and thank you for joining us again this morning in Cardiovascular Medicine Grand Rounds. Just a few housekeeping things. Questions, if you can save until the end of the presentation, you can ask questions by typing into the chat function or just using the hand raise function. With that, we'll go ahead and get started. It's a pleasure to have Dr. Amanda Vest with us today. Dr. Vest is an associate professor of medicine and the medical director of the cardiac transplantation program at the Tufts University Medical Center. Originally from the UK, she completed medical school and internship at Imperial College London before moving to Boston for internal medicine residency at BU. She then completed cardiology fellowship and heart failure training at the Cleveland Clinic in Ohio and returned to Boston in 2014 to Tufts University. Her research interests are based around the interactions between heart failure, metabolic dysfunction, and body composition. She started her work really looking at the important relationship between obesity and heart disease, including the impact of bariatric surgery on cardiovascular health. She will speak to us today, I think, on a very important topic on nutrition, obesity, and cachexia in patients with heart failure. So thank you very much, Dr. Vest, for joining us.
Oh, thank you very much for that kind introduction, and lovely to be with you all this morning. Thank you for being interested in this topic of nutrition, obesity, and cachexia in patients with heart failure. I hope to take you through a range of these clinical issues, which I think are, very important and not always fully addressed in our heart failure clinical practice, and touch a little on the research topics that I'm currently interested in, and I'd love to discuss more with you and see how they intersect with your areas of interest. My disclosures are as follows: cite PI on some of the heart failure trials, and acknowledging research funding from the AHA and Tufts CTSI. And these are the topics that I'll be covering today, starting with overall nutrition guidance aimed towards patients with heart failure, followed by obesity in patients with heart failure and evidence for the weight loss therapies, and then onto the topic of cachexia and skeletal muscle wasting in patients with heart failure, finishing off with a call for more clinical trials in these areas. So our three big topic areas will be the dietary patterns, obesity, and cachexia. Well, we now have a plethora of studies from observational cohorts indicating that certain dietary patterns are associated with increased incident heart failure risk, including fried foods, high dietary protein, sugar-sweetened beverages, processed red meats. Conversely, DASH or Mediterranean dietary patterns and the intake of whole grains, fruits, vegetables, and fish are associated with reduced rates of incident heart failure and are therefore well established as primary prevention strategies. However, I should note that in the one prospective clinical trial of Mediterranean dietary patterns called PREDIMED, incident heart failure rates were actually no different between the Mediterranean and low-fat dietary groups, although probably underpowered for that endpoint. For patients with established heart failure, we have very little data on what to advise with regards to dietary patterns for secondary prevention of mortality or prevention of other adverse events. The DASH diet, which is, of course, dietary approaches to stop hypertension, shown here, is low in sodium, high in fruit, vegetables, grains, and low in sugar, and therefore is a good and attractive choice for patients with heart failure. The most quoted data from mechanistic studies are from Scott Hummel regarding the DASH diet and improved blood pressure, some improvements in arterial stiffness and diastolic function, although these are in cohorts of only 13 patients. There was also an analysis of the WHI, which suggested women with heart failure and dietary patterns that scored more consistent with DASH had lower mortality, but this has not yet been proven in a prospective clinical trial. As a result, you will see essentially no recommendations in the overall heart failure guidelines about which dietary patterns to endorse for our patients with heart failure, and only some somewhat controversial guidance about sodium restriction that, as I'm sure you know, isn't all that well supported by the current literature. Well, there are 2 current randomized controlled trials that will report out regarding sodium intake and hopefully better define our future practice with regards to salt. And so I'm not going to focus any further on the salt intake question. But meanwhile, I will state that it was this sort of narrow attention towards sodium restriction in our heart failure guidelines and the potential for overly restrictive dietary counseling that this can sometimes generate, which led us to write a consensus statement from the Heart Failure Society of America on nutrition, obesity, and cachexia in patients with heart failure. So the recommendations on which we were able to reach agreement are as follows. We should beware the risks of restrictive dietary counseling, which can prompt micronutrient inadequacies and weight loss. We overall would endorse diets based on DASH, Mediterranean, or plant-based patterns. Of course, reducing calories for those with excess weight or being mindful of sugar for those with diabetes. We felt that a whole food approach was much more valuable than focusing in on single supplements or single nutrients within the dietary pattern. And then recommending at least the population minimum of 0.8 grams per kilogram of body weight of protein intake, and potentially more in individuals with skeletal muscle wasting, although there are some concerns around red meat intake and the implications for coronary artery disease. I would also like to take a moment here to acknowledge the key role of the registered dietitian nutritionist with a figure from that statement. Our colleagues as RDNs are valuable, of course, for performing both nutritional evaluation and counselling of our outpatients or inpatients with heart failure, which should ideally be available to every patient with heart failure. However, we recognised in our HFSA statement the limitations to access to registered dietitians, and so use this figure to guide the highest yield patient subgroups on areas where we should all be able to do some nutritional consultation. In fact, you may be aware that RDN access is only covered by Medicare for patients who have diabetes, CKD, or are within 3 years of a kidney transplant. So heart failure isn't one of those approved indications where there's guaranteed coverage. So having covered a little bit of the topic of overall nutritional health for our patients, I'd like to move towards this key topic of obesity in patients with heart failure. As I'm sure you know, there's a very clear and robustly established link between excess adiposity and subsequent heart failure development, even adjusted for the most common confounders. This excess in risk is most evident for individuals with a BMI of 30 and above, and so maintenance of a normal range BMI throughout the lifespan is a cornerstone of our heart failure prevention guidance. The mechanisms linking obesity and heart failure are summarized in this very recent scientific statement and include inflammation, insulin resistance, hypertension, to name but a few. Although we do have several pediatric studies that demonstrate that obesity has a direct effect on LV mass independent of systolic blood pressure elevations. It is known that as little as 10% of body weight loss for those who need to lose weight can significantly improve cardiometabolic status and therefore could be reasonably expected to prevent heart failure. In this large meta-analysis, incident heart failure risk increased by 41% per 5-unit increment in body mass index. We should keep in mind during this discussion that the dose-response relationship between BMI and incident heart failure appears to be strongest for heart failure with preserved ejection fraction as compared to reduced ejection fraction. Now, the substantial weight loss that we see after a bariatric surgery is known now to be associated with improvements in the structure and function of the heart. In this systematic review from some years ago, we saw regression of left ventricular hypertrophy and diastolic dysfunction across 700 patients with mean 35% weight loss at 20 months. Importantly, the improvement in LV mass was independent of systolic blood pressure. And these observations suggest that reversing LV hypertrophy and stiffness are likely key to the prevention of heart failure with weight loss, especially HFpEF, and infers that patients with established heart failure could potentially achieve improvements in cardiac structure and function with successful weight loss. But to truly prove this obesity incident heart failure link, I can now present 5 retrospective cohort studies demonstrating the value of surgical weight loss for the prevention of future incident heart failure. Now, these primary prevention studies were conducted in the US and Sweden with a variety of comparator groups, but are actually surprisingly consistent in their findings of around a 50% reduction in incident heart failure for the adults who undergo a surgical weight loss procedure. Unfortunately, none of these studies give any specificity on the HFpEF versus REF phenotype, but looking at the female predominant demographics, we could speculate that it's predominantly HFpEF that is probably being prevented. So, although we can now be confident of the case in favor of treating obesity to reduce incident heart failure, the controversy really arises when we move to the discussion of treating obesity to improve the health and future event rates of individuals with established heart failure. This figure represents a meta-analysis of 11 studies incorporating 41,000 patients with a mean age of 67 years. Cardiovascular mortality was lower in the overweight group, that's BMI 25 to 29, relative to the normal BMI group. Unlike some other studies where patients with obesity, that would be BMI of 30 and above, had lower rates of cardiovascular events, and we call that an obesity survival paradox. Here we just see that the obesity group, that's patients of 30 and above, had about the same rate of events as those in the normal range BMI group. But because of this concern about the paradox, we don't routinely recommend weight loss for individuals with overweightness, BMI 25 to 29, and it's created a lot of uncertainty around whether or not we should recommend individuals with a BMI of 30 above to intentionally lose weight in the setting of a heart failure diagnosis. And really the challenge in interpreting this obesity paradox is that there is not only inadequate adjustment for some of the potential confounders, there can be a lead time bias and lack of specificity in the heart failure diagnosis for individuals with obesity, where that endpoint can be harder to determine, but also the unknown negative consequences of patients who are unintentionally losing weight during their heart failure disease process. And of course, we're going to talk a little bit more about cachexia, but here we may be seeing that phenomenon in a Spanish cohort of consecutive outpatients with heart failure, mostly individuals with reduced ejection fraction. And within the group, there were 275 patients with obesity. And for patients with baseline obesity who lost 5% of their body weight over 1 year, and that's shown here in yellow, the survival was significantly lower. However, given that that yellow line presumably reflects this combination of patients who are intentionally and unintentionally losing weight, this figure may just be predominantly reflecting the negative consequences of cachexia and malnutrition. And so taking all this data together, I would like to begin to make the case for why we perhaps should be more proactive in engaging patients with established heart failure and significant obesity in weight management strategies. And I'm going to hopefully support that more with data on the coming slides. Some of the reasons I think this is relevant to our patients is that loss of weight may help to provide symptom relief, improve fitness, quality of life, and as I'll show you, potentially fewer heart failure hospitalizations. As we've seen, I think it's realistic to expect that individuals with a lot of excess weight may experience improvements in myocardial structure and function, including reduced LV mass and diastolic stiffness. There's a lot of data to support that we can help our patients reduce comorbidity burden, including AFib, DVT, sleep apnea, and diabetes severity. Furthermore, in our young patients who may otherwise be a good heart transplantation candidate, this is a particularly important intervention to help our patients access that therapy if their BMI otherwise would contraindicate it. And so when we consider the management of obesity in patients with heart failure, we have to think about 3 categories of management. That would be lifestyle, pharmacological, and bariatric surgery. And I will now present to you the data specific to patients with established heart failure that cover each of these 3 domains. So firstly, we'll look at dietary interventions for weight loss in those individuals with heart failure who do need to lose weight. This is a table that actually covers all the available trials to date, so we are fairly limited. And notably, only 3 of these randomized studies actually achieved successful weight loss. At the top, from Evangelista, we have a 14-patient HFrEF pilot study. And then at the bottom, a 76-patient full randomized control trial from the same group. That was for patients with heart failure with any ejection fraction, plus this 100-patient HFpEF study. You can see in these cases, there was successful weight loss and other cardiometabolic benefits seen. And based on small heart failure studies such as these, and the larger weight loss studies outside of the heart failure world, the following practical considerations for weight loss should probably be considered. We should emphasize 3 balanced meals a day when counseling patients, recommend increasing fiber from whole grains and vegetables, which helps us to feel full up, and also include protein with all meals and snacks. Protein suppresses ghrelin release and is another very powerful strategy for helping suppress hunger in patients who are losing weight. Very importantly, we should counsel patients about their beverages, especially replacing juice or sweetened beverages with water or other zero-calorie options. Many patients are quite unaware of how many grams of sugar exist within their bottle of soda. And so this is an important area of counseling that we can really make meaningful changes with. And ideally, all of this should be delivered within a dietitian-led behavioral weight loss management program. And it's recommended that really any patient losing weight, especially for somebody with heart failure who has a number of comorbidities, only lose at most 1 to 2 pounds per week. You may find, if your clinic is anything like mine, that there are a lot of questions about newer dietary patterns or popular diets that come up. So what if my patient wants to try, for example, a ketogenic diet? This is tricky. There are certainly many people who have good success, at least in the short term, with having some nutritional ketosis. And it may be an appropriate diet for a short period of time to get people off on the right foot. However, we have to be very careful if our patient has diabetes, especially if they're using insulin due to the potential for hypoglycemia or DKA. And so management of dietary choices and potentially close electrolyte management would be very important. Intermittent fasting, or time-restricted eating, as it's more correctly known, has become increasingly popular. We have a couple of studies now showing that for isocaloric comparisons, so if you make sure that both study groups are taking the same number of calories a day, that time-restricted eating probably doesn't induce any additional weight loss over an overall sensible diet. But some patients do find this useful. Again, some dangers though, if diabetes and insulin use is part of the patient's background. And then there's all manner of cleanse diets, as you know, which are usually not at all evidence-based and could be dangerous, especially for a patient at risk of electrolyte disturbances. So definitely important to talk to our patients about how they're planning to lose weight and make sure that they're thinking of doing so in an appropriate way, if indeed they even do need to lose weight. Looking now at the exercise part of weight loss specific to our patients with heart failure and obesity, we have HF Action, which, as you may know, examined the effect of an exercise intervention in over 2,000 patients with systolic heart failure. And not shown here is the overall non-significant trend towards lower mortality and fewer hospitalizations in that exercise training group. At baseline, the impairment in quality of life for patients with obesity was actually seen to be greater in women than in men. The exercise intervention was associated with improvements in quality of life for all of the BMI subgroups, with greater benefit in those with higher BMI categories. Shown here for the subcategories with obesity in these red boxes, the median weight loss over the 3-month exercise intervention was ultimately disappointing at around 0.5 kilogram of weight lost. So ideally, exercise should be part of any lifestyle weight loss intervention, although the amount of weight loss achieved by it and the feasibility in a patient with symptomatic heart failure may not always make exercise the best piece of a dietary and weight loss intervention. Our next category is weight loss pharmacotherapy, which poses particular challenges for our patients with heart failure. Standard indications for pharmacotherapy for weight loss are a BMI of 30 and above, or 27 and above with other obesity-associated comorbidities, and of course, an appropriate risk to benefit profile of taking that medication. This table displays the FDA-approved medications that we have as options, most of which have not been tested in patients with heart failure. Standalone use of phentermine and the other related amphetamines is usually avoided in patients with any cardiac disease, of course, because of the known heart rate and blood pressure elevations. Orlistat is associated with modest reductions in blood pressure, albeit also with more modest placebo-adjusted weight loss in the range of just about 3 kilograms. Greater weight loss efficacy is seen in these combination medications, with modest improvements and no major increases in heart rate or blood pressure. There is no data on which to assess the safety of phentermine topiramate, for example, in patients with heart failure, but there was a reassuring cardiovascular safety study for bupropion naltrexone, although patients with NYHA class 3-4 heart failure were excluded, and heart failure was not a reported endpoint. The Glp-1 agonists have recently been proving their efficacy in weight loss. So we have liraglutide, now specifically FDA approved at the 3 milligram weight loss dose, and more recent data from the STEP studies showing that semaglutide could achieve impressive weight loss efficacy for patients with or without diabetes. I'll next take you through some of the drug data that we have, though, specific to patients with heart failure. We have a pilot study of 21 patients with HFrEF from Canada, where participants were randomized to 12 weeks of orlistat versus standard of care. The orlistat group achieved a 5% absolute reduction in body weight over the 12 weeks, and this was associated with significant improvements in 6-minute walk test and NYHA functional status. The drug was well tolerated and improved lipid profiles. As just discussed, the GLP-1 agonists are now becoming increasingly established as a tool for aiding with weight loss in a patient with or without diabetes. They're probably a good choice for many of our patients with HFpEF. But shown here is the data that you'll recall for patients with HFrEF. We have the FIGHT study examining liraglutide for the treatment of HFrEF, where participants receiving liraglutide in blue had an average placebo-adjusted weight loss of 2% or 4.1 pounds. However, as you will recall, this overall study was neutral, with a non-significant trend towards more death and rehospitalization in the liraglutide group. That's the darker line here. So this certainly does raise some safety concerns around the use of liraglutide, specifically in this population who had advanced HFrEF. The third category of weight loss interventions is bariatric surgery. Now, the commonest bariatric surgery for patients in the US is currently the laparoscopic sleeve gastrectomy, followed by the Roux-en-Y gastric bypass. I am, of course, only suggesting bariatric surgery for patients who meet the indications in red, which include a severely elevated BMI and lack of success with the lifestyle and pharmacological measures that we've already discussed. But the reason that patients do consider surgery is because weight loss success is low with lifestyle and medication strategies, usually in the realm of just a 5% sustained weight loss over time. Conversely, here in the randomized STAMPEDE trial of medical therapy versus surgery for patients with type 2 diabetes, the average surgical weight loss at 5 years was 20%, or 8 BMI points. Not only does bariatric surgery offer superior sustained weight loss efficacy, but also in the modern era, a minimal risk profile for these contemporary laparoscopic surgeries, with a 0.1% 30-day mortality rate in the general MISQUIP registry population. It is also worth noting that the prevalence of diabetes, hypertension, and hyperlipidemia reduced by about a third in the medium term after a bariatric surgery. Now, specific to heart failure, there is evidence that heart failure hospitalizations may decrease after bariatric surgery. This was a self-controlled case series of patients with heart failure and obesity who underwent bariatric surgery using administrative data from 3 US states. It demonstrated a reduction in ED visits and hospitalizations for heart failure exacerbation in the 13 to 24 months after surgery, as compared to the window of 13 to 24 months before surgery. However, patients who died postoperatively were excluded from this analysis. So before recommending surgery to a patient with heart failure, we do need to understand a little bit more about the operative mortality risk within this type of patient group. And in that regard, we examine mortality data from the nationwide inpatient sample. This plot compares the adjusted odds ratios of major in-hospital events for patients with HFrEF at baseline in red and for HFpEF in blue. And all these patients underwent a bariatric surgery. They're being compared to the general population without heart failure who also went to bariatric surgery in the same hospitalization. Concerningly, as you see, there was an increased odds ratio for mortality for the patients with HFrEF in red. For the patients with HFpEF in blue, this was a non-significant trend with an adjusted odds ratio of 1.5. Clearly, though, this raises some questions and presents an area where we really need to look at surgical patient selection, preoperative optimization, and postoperative heart failure management to really understand how this patient group can safely come through a surgery and know what the strategies are that we as cardiologists can provide to optimize patients for their procedure. Also of interest is myocardial function after bariatric surgery. There's a host of case reports on this topic and a few small retrospective studies of bariatric surgery for patients with a baseline LVEF abnormality. We summarized some of them here in a prior paper, and although there's a potential for increase in LVEF with surgical weight loss compared to weight match controls, there's likely a lot of publication bias. And in our 2016 study, we found, although a statistically significant uptrend in EFs, not really any evidence of clinically meaningful benefit in those who had a bariatric surgery compared to weight match controls also with obesity. So I think it would be a mistake to counsel patients that a bariatric surgery is going to have a dramatic effect on LV function, even though I do admit there are case reports where there has been significant myocardial recovery after substantial weight loss. We are now fortunate to have 4 publications that characterize the role of bariatric surgery for longer-term mortality prevention among patients with baseline heart failure. In these first 2 US administrative database studies from Aliasa and Hahn, patients hospitalized with heart failure who had a history of surgical weight loss had lower odds of inpatient hospital mortality than the equivalent patient group with heart failure and obesity who had not had a prior bariatric surgery. Then, in a recent registry-based Swedish cohort, A group of 142 patients with pre-existing heart failure was specifically analysed and had a 77% lower mortality hazard compared with non-surgical matched controls. Similarly, in a Canadian cohort from Dolores, these subgroup of patients with pre-existing heart failure showed lower cardiovascular mortality and all-cause mortality with a hazard ratio of 0.43 for those with a prior bariatric surgery, as well as a lower rate of subsequent heart failure hospitalization versus propensity score matched controls. And here's the key figure from that Dolores paper. We have 548 patients, all with baseline heart failure, and we see that the primary endpoint of a 5-point MACE composite, that's mortality, MI, revascularization, stroke, and heart failure hospitalization, occurred in 100 patients in the non-surgical group versus 47 patients in the surgical group in red, with the Kaplan-Meier curve separating out over a short period of time, well within 2 years. So to summarize, here are some of our strongest heart failure specific data regarding weight loss for patients with obesity, for lifestyle, for pharmacotherapy, and for bariatric surgery interventions. Now, I admit it's not the highest quality data, but it does at least support the assertion that weight loss for patients with heart failure is feasible and potentially beneficial if we look at these bariatric surgery studies. Now, a subgroup of patients with heart failure, where it's particularly important to get this information right, are our individuals with end-stage heart failure who receive a left ventricular assist device. And I know this is a population group that is very familiar to you as it is to us. And so we'll turn specifically to our patients with obesity who are LVAD recipients. A third of American adults meet BMI criteria for obesity, so it's not surprising that obesity is a similarly common comorbidity amongst our LVAD patients. In an international IMAX cohort, 29% of LVAD recipients had stage 1 to 2 obesity at the time of implantation, so that means a BMI in the 30s shown in maroon. Almost 5% had stage 3 obesity. That's a BMI of 40 and above, shown in pink. Similarly, in an analysis of the advanced cohort, led by my colleague Mike Kiernan, more than a third of LVAD recipients had obesity, as shown. For patients who receive an LVAD, weight gain during support is very common. The tendency towards weight gain has been attributed to a combination of increased appetite and reduced catabolic metabolism once the patient is supported with an LVAD for treatment of their heart failure syndrome, as well as this limited capacity to exercise for individuals who are living with an LVAD. The greatest degrees of weight gain are usually seen amongst patients who were underweight at the time of LVAD implantation, represented here in the turquoise line. But individuals with overweightness or obesity at LVAD implantation do often gain further weight unless a specific weight management plan is put into place. A recent Intermax report described that among patients with a BMI of 35 or above at implantation, only 18.6% lost weight during LVAD support. Most single and multi-center reports have not shown obesity to be associated with any higher mortality after implantation, but several studies highlight associations with other important LVAD adverse events. Driveline exit site infections have consistently shown an association with obesity, as illustrated here. Several publications from the Intermax and IMAX datasets have highlighted increased risks of non-VAD associated infections, pump thrombosis, right heart failure, and hospital readmissions. The advanced cohort also showed an increased risk of AKI for patients with severe obesity, in addition to lower patient-reported health status by KCCQ and lower functional capacity by 6-minute walk tests for patients with BMIs above 35, who are shown here in blue. Although both BMI groups showed improvement after Lvad implantation in their functional capacity, and the analysis for an interaction between BMI groups was non-significant, this trend towards a lower functional status for patients with obesity who receive an Lvad is an important message to keep in mind, especially for those whom we're considering an implantation as destination therapy, who may have many years supported on their Lvad. Now, this figure from a recent ACC opinion article written with Dr. De Silva de Abreu, who I know you all know well, summarizes pathways for patients with advanced heart failure and obesity. Many patients will ultimately be offered a destination therapy Lvad with that hope that they will attain the required BMI for transplant listing at the specific center. So this pathway is shown through here in a red line towards transplantation. Perhaps they will even achieve myocardial recovery during their period of Lvad support with some weight loss. Unfortunately, though, there's a large risk that they will experience additional weight gain and the potential for an increasing burden of comorbidities and VAD complications that ultimately take them further away from their transplantation goal. However, bariatric surgery can be a successful bridge to transplant pathway for our patients with a baseline high BMI. And again, from Adrian, we have this recent 29 patient systematic review of individual patient data, which brings together many of the smaller case reports describing outcomes of bariatric surgery during an Lvad bridge towards transplant. This was a young cohort with a mean age of 42, and the majority receive a laparoscopic sleeve gastrectomy. 39% had perioperative events, but weight loss efficacy was good, and almost half of the group achieved heart transplantation within the 14-month average follow-up period, with no deaths up to 1 year post-transplant. 78% achieved the composite endpoint of a BMI less than 35, transplant listing, or LV recovery. Another systematic review broke the analyses into simultaneous procedures, meaning same day Lvad implantation followed by a bariatric surgery, versus stage procedures, where there's an interval of months or years between the two surgeries. Little can be concluded about the relative risks and benefits of the two approaches from this data, but it is notable that there were 6 mortalities amongst 53 bariatric surgeries. Also, the postoperative complication rate was much higher than that we saw in the routine registry statistics earlier on in this talk. Almost half of patients experienced complications, which were mainly postoperative bleeding, staple line leaks, and arrhythmias. This underscores that our Lvad population is a very high-risk group of patients for any surgical procedures. And although the majority of patients will survive a bariatric surgery, we still need high-quality data about the adverse event rates, mortality risk, and how we should optimize patients and really prepare them for success for such a surgery. Ideally, the next wave of data on this topic should capture the trade-off between these bariatric surgery postoperative adverse events and the potential adverse events of remaining on an Lvad long-term if transplant does not become an option because of the BMI. So to wrap up my comments on obesity for patients with heart failure and Lvads, I'd like to provide a few practical tips that we've learned in our Lvad program. Best practice is probably to engage all patients with obesity at the time of Lvad evaluation in a multidisciplinary weight and wellness plan, especially given that the likelihood of further weight gain on the VAD is high. Laparoscopic sleeve gastrectomy has become the preferred bariatric surgery in this group because of the fewer surgical anastomoses and less malabsorption. There are also shorter recovery times than some of the other procedures. Now, if you're caring for such a patient, please be very cautious regarding warfarin reintroduction after the bariatric surgery. Most patients will need a significantly lower warfarin dose than they did preoperatively. Also, blood pressure lowering medicines may need to be dose reduced whilst the patient is rapidly losing weight. Of course, we have more options with temporary mechanical support these days that could provide sufficient support around a bariatric surgery as opposed to a durable Lvad. But anticoagulation strategies during this temporary MCS support bridge would have to be really carefully thought through. And further work needs to be done to resolve the risks and benefits of the staged versus simultaneous Lvad and bariatric surgery procedures. My take on this topic is that patient education and lifestyle adaptations are significant for each of the individual surgeries of Lvad implantation and bariatric surgery, and trying to attempt both of them in the same hospitalization is a lot for both the patient and the family to cope with. Therefore, I hope I've shown you some data that suggests that the majority of our patients with heart failure and severe obesity may benefit from weight loss as a strategy to improve symptom burden, improve functional capacity, reduce heart failure hospitalizations, improve their transplant eligibility, and reduce VAD complications and enhance overall survival. So I believe that we can and should pursue weight loss therapies when the BMI is above 35, shown here in the green box, especially for patients with a BMI of over 40, and particularly those with HFpEF, where the operative risk appears to be lower. Bariatric surgery is a reasonable approach. Now, this should be done at a center with expertise, not only in bariatric surgery, but also in heart failure to really optimize patient outcomes. At present, I acknowledge that we have uncertainty about the relative risks and benefits of weight loss for patients with a BMI in the 30 to 35 range, that's shown in orange. And therefore, we have to individualize management based upon the burden of comorbidities, the symptoms, and patient preference. For patients with an overweight BMI range, that's in the 25 to 29 range, I don't think at this time there's any evidence that weight loss is beneficial, and so just an overall healthy lifestyle plan would be appropriate for patients in this group. In my opinion, the retrospective surgical data has really set the stage for a prospective clinical trial of sleeve gastrectomy versus standard medical care in patients with HFpEF and obesity. I know there have been a few preliminary discussions about a multi-center grant over the last few years, but nothing's gotten off the ground to my knowledge. I'm very hopeful, though, that this will be accomplished in the coming years and would be very excited for any collaborations if they should arise. Now I'll turn in the final minutes to our last topic, which is cachexia in heart failure. We know that malnutrition occurs quite commonly in patients with HFrEF, but as shown in this British cohort, the exact prevalence depends upon which malnutrition screening tool we're using to assess risk. And each of the tools shown here have shown good performance, with the GNRI showing incrementally worse survival for individuals screening in for mild, moderate, or severe malnutrition. There was a very exciting JACC paper just a few months ago from Switzerland describing a clinical trial of hospitalized patients with chronic heart failure who screened in for malnutrition. The group was randomized to individual nutritional support versus standard of care. And those with the individualized nutrition support had a reduced risk for 30-day mortality as compared to the comparator group. On the right, the subgroup with the highest malnutrition risk, meaning the highest malnutrition scores at baseline, had the greatest separation during the intervention between nutritional support and control groups. And so this is the strongest evidence thus far that treating malnutrition may be effective in improving hard outcomes for our patients living with heart failure. A related construct that we all see very commonly in our advanced patients is wasting of chronic disease. The definitions and diagnostic criteria are not well validated at this time, and significant overlap does exist. But cachexia is generally defined as a complex wasting syndrome characterized by unintentional edema-free weight loss, often a threshold of 7.5% is used, that is accompanied by inflammation and abnormal biochemistry. Conversely, sarcopenia is the age-related decline in muscle mass and function, which can be accelerated in the setting of chronic diseases. And as shown to the right, both cachexia and sarcopenia have been associated with significantly worse mortality outcomes for patients with ambulatory heart failure. The extent to which inadequate caloric intake, especially protein, contributes towards this muscle wasting in advanced heart failure is a matter of some controversy and is actually the objective of my current grant application. But there are some key distinctions here between the wasting disorders as shown and malnutrition, in that urinary nitrogen excretion is low in the setting of malnutrition starvation, where the body's trying to hold on to its protein stores, whereas nitrogen excretion is high in cachexia because there's catabolic metabolism and inappropriate muscle breakdown and wasting of that protein out into the urine. One of my key current research interests is reversal of this catabolic muscle wasting. And interestingly, if we take a look back at the seminal HFrEF medication trials, we do see some evidence that unintentional weight loss can be attenuated by enalapril and carvedilol. However, the most dramatic example of wasting reversal that we see in heart failure cardiology occurs after our deployment of advanced heart failure therapies. So it turns out that Lvad implantation is an excellent opportunity for us to study the potential for recovery from cardiac cachexia as we bring our patient out of the advanced heart failure syndrome. And in recent years, I've been fortunate to study the changes in body composition after Lvad implantation. And here we see one of our participants in a study who met criteria for both cachexia and sarcopenia at baseline. And you can see over time, this pronounced loss of subcutaneous fat and muscle does begin to improve with concurrent improvements in appendicular lean mass, that's ALM, on the DEXA scan. Within 6 months of Lvad support, he had actually achieved significant muscle mass recovery and no longer met the DEXA criteria for sarcopenia. We found this to be common across our cohort of 30 patients enrolled in our prospective study at Tufts. There were significant increases in fat-free mass between Lvad implantation and 3 and again 6 months of Lvad support. The same pattern was seen for the appendicular lean mass, in which 82% of participants achieved a 5% or greater ALM increase during this 6-month period of Lvad support. Conversely, on the right, although fat mass trended up, it was not a significant increase over the same period of time. So in this project, which we're happy has just been accepted for publication, we saw a 52% prevalence of muscle wasting at baseline by DEXA criteria, and then a mean increase in fat-free mass of 2.3 kilograms over the first 3 months of VAD support. There was a high agreement between our DEXA method and the reference technique of deuterium dilution. Although it was great to demonstrate that muscle wasting can recover with aggressive treatment of the heart failure syndrome, the next question in our research program is whether nutritional or pharmacological interventions can also reverse cachexia in patients with wasting during heart failure, given that the majority of our patient population obviously won't be eligible for an Lvad implant. We have a fairly robust understanding at this point of the molecular pathways governing protein synthesis versus protein degradation, and a good appreciation that we need to harness therapies that tip the balance in favor of protein synthesis. A lot of this information actually comes from the cancer cachexia world. And the question at this point is, which pathway Or maybe which combination of pathways would we need to manipulate to achieve the more protein synthesis and less protein degradation effect? At present, the most promising candidates are dietary interventions, either with protein supplementation overall or using specific amino acids. The omega-3 fatty acids have also shown some efficacy in terms of prevention of cachexia. Leading candidate pharmacological strategies are GDF-15 neutralization or activin A, or I should say the activin type 2 receptor pathway inhibition. Each of these have therapies that are currently under development, mostly in phase 1 studies with the pharmaceutical companies. But there are some realistic options here of pharmacological treatments that might be able to combat some of the skeletal muscle wasting and also some of the anorexia that goes along with our weight loss syndromes. And at this point, I believe the key clinical trial that we should be pursuing is an oral protein supplementation versus standard of medical care intervention for patients with heart failure and muscle wasting. We routinely recommend protein calorie supplementation to patients with evidence of wasting, but we have no specific data at this time to determine whether this provision of protein is actually effective in rebuilding new muscle mass. I'm hoping to get this funded in future, and if there's any interest in collaboration, would love to discuss. So in summary, the key points from this lecture are that overall, we should be endorsing diets based on the DASH, Mediterranean, or plant-based patterns for our patients with heart failure. We need to be mindful of avoiding restrictive dietary counseling to try and avoid malnutrition or muscle wasting. For patients with severe obesity and heart failure, I hope you have now enjoyed seeing some of this retrospective data that supports bariatric surgery when the severe obesity for endpoints of mortality and heart failure hospitalization reduction. You've also heard that although we commonly offer oral protein supplementation to our patients with heart failure and evidence of wasting, we don't have any robust data to support that this is an effective intervention, and it's prime time for that to be studied in cardiac cachexia. I'm hoping that the next steps will be considering these types of clinical trials, an oral protein supplementation intervention for those with wasting, and hopefully in future, a study of bariatric surgery in individuals with obesity and HFpEF, which I think has very significant impact on our understanding of how we manage patients with obesity in the clinic. And so with that, I'd be happy to take any questions from the group.
Thank you so much, Dr. Vest. I think that was a wonderful talk, I think, in a topic that we perhaps don't spend as much time as we should, really sort of thinking about and understanding in our patients with heart failure. We've had just as a chance to ask questions again, using the chat function or just by hand raise. Dr. Nudell, you had some questions directly to me, so I'm going to ask you to unmute and make your comments and question. All right. Matt will have Matt Berg ask his question, and maybe I'll ask Dr. Nudell's question afterwards.
Yes, thank you very much. A very interesting presentation. I'm very encouraged by the ideas that you present, particularly around prescribing particular diets for patients according to their presentation, and at the same time, even where bariatric surgery might be involved, and understanding that while the data you presented are very strong around bariatric surgery, we also know that a lot of people who undergo bariatric surgery do not sufficiently alter their lifestyle and therefore gain weight back. Mm-hmm. And so what this points to me is that, number one, if we're prescribing a diet, it's not the same thing as prescribing a medication, which is easy enough to take, albeit that many patients, particularly those who are depressed, are non-adherent with taking their medications. It points to me the need for a counseling or coaching infrastructure to support patients in making these lifestyle changes and understanding the factors that are contributing to the diet and their current lifestyle, and how they, the support they need to make those alterations. And similarly for the patients who undergo bariatric surgery. Can you speak to those types of needs and how well that type of infrastructure is in place and what we need to put it in place?
Absolutely. You're 100% right on that. And really, both the studies and clinical experience have shown that the most successful weight loss outcomes for patients who do need to lose a substantial amount of weight is achieved within behavioral-based, dietitian-led, multimodality programs. Weight regain is common across these interventions. Bariatric surgery, for example, the nadir in weight is usually at around 1 year post-surgery, with some weight regain expected thereafter. Not only do we have to be thinking multimodality in terms of using a clinical psychologist often, as well as a dietitian and sometimes a physician as well, but we have to be multimodality even in our weight loss interventions. And I think a noticeable change in the obesity management field in recent years has been the idea of combination therapy. Of course, we're all very used to that in cardiology, but now the idea that not only do we need to have great lifestyle interventions in place if a bariatric surgery is going to occur, but then often pharmacotherapy is going to come into the picture as well at that point where the weight regain unfortunately begins to occur. And so increasingly we're seeing the weight loss physician as part of the group perhaps beginning a GLP-1 agonist a year after the bariatric surgery when things start to go in the wrong direction. So I definitely agree that this multimodality, multi-specialty collaboration is the way to appropriately support our patients. And of course, it only gets more complicated if you bring heart failure as a disease process or even a Lvad into the mix, and that multidisciplinary support needs to be all the stronger. And I thought it was very insightful that you mentioned depression as well. We know that such a proportion of our patients living with heart failure are depressed, and that clearly there's an overlap in terms of eating behaviors, and a big portion of the bariatric surgery assessment is actually around mental health, substance use, and the risk of a mental health deterioration during the surgical process. So very important that behavioral health is part of the mix. I think a few centers do this really well, but unfortunately the vast majority of patients in the US who could benefit are not getting access to this true multidisciplinary help.
Was certainly something for us here at Yale to aspire to.
Yeah, that's all.
Dr. Nudell, I'll have your comment and question. Thank you.
Yeah, hi, sorry for the technical malfunction. Two questions. One is maybe we should measure percent body composition rather than just weight and BMI in heart failure patients. Another question is, what is the long-term risk of trace to mild ketosis in a carefully monitored patient? And the last thing is a comment. Your lecture, excellent lecture, is an example of why cardiologists should be at the center of weight loss for medically complicated patients. We are always clearing them for surgery anyway. We should be at the forefront of this. Thanks.
Thank you. Thank you very much for your comments. And yes, I do very much subscribe to that last point as well. Ultimately what we're trying to achieve now, and as the studies are beginning to move in this direction, we can actually see as realistic is longer life. And that really in this patient population means prevention of cardiovascular events. And so cardiologists clearly have a role here on multiple levels. To take your first question about body composition assessment in patients with heart failure, Absolutely. This is a key weakness and limitation of many of the existing studies and of many of the things that I would like to try and do and measure and prove in patients with heart failure as it relates to both the obesity side of things and the wasting side. And we desperately need better ways of assessing what is happening to a patient's body composition than just having them hop on the scales. Obviously, massive confounding, especially when we've got shifts in fluid retention in this patient population. We use DEXA scan a lot, and as mentioned, we have been able to validate this in the patient population through a reference isotope technique. DEXA obviously isn't available routinely at most heart failure clinic settings. So at least on the wasting side, we are currently working on using skeletal muscle ultrasound. We've found that the biceps point, so measuring up here at a certain anatomical point, the muscle thickness at the bicep correlates really fairly well with appendicular lean mass on the DEXA. And I think we could all imagine that just wheeling an ultrasound machine to the bedside or into the clinic room is a way that we could realistically at least assess muscle wasting and understand which patients are becoming cachectic in our clinics. So that is a opportunity that we're hoping to expand upon. Other ideas for how we could easily measure body composition in your clinics, much welcomed. And then to your second question, the long-term effects of nutritional ketosis. I think this is fascinating. And as you'll be no doubt aware, the data that we do have is not long-term. It really only spans some months. And most of the studies regarding nutritional ketosis look at individuals with diabetes, type 2 diabetes, or there is some data from aging in general, showing some anti-inflammatory and potentially beneficial effects in terms of insulin resistance and so forth. It has been postulated, but I do not see it well proved, that a low-grade nutritional ketosis has some diuretic effects. So I think that's something that really should be prospectively studied. There's also a couple of nice animal data and a couple of human suggestions that getting somebody into nutritional ketosis may have positive hemodynamic effects. The best data is just animal data at this point, where infusions of ketone bodies have been made. And I think that's a really intriguing possibility that it really behooves us as cardiologists to figure out. Longer term, of course, it is hard for anybody, I think, to achieve and maintain nutritional ketosis for more than a few months. And in fact, if we look at population data, for example, from ARIC, it would suggest that dietary patterns that are a little bit more in that direction are perhaps not associated with the best cardiovascular health long term. So we do have to be a little bit thoughtful about whether ketosis longer term is good for cardiovascular health in terms of atherosclerotic disease progression. There's some data that maybe it isn't. So a lot of great points there that you raise, and I would love to understand better the hemodynamic effects of ketosis.
Thank you so much. We're right at the top of the hour. Dr. Velasquez, if you're still on, I might allow you a comment. Not sure if we have...
I think I see the comment in the chat box. And very briefly to answer the question, thank you so much, is the prevalence estimate of BMI greater than 40 amongst NYHA 2 to 3 HFrEF and HFpEF patients. The data that we have from a few kind of composites of trials is that it's at least a third, so over 40. So BMI of over 40, we're talking about at least 10 to 15% of patients in clinical trial settings, and a little bit higher in the HFpEF setting. And then in this era, do you believe an active comparator with a drug, i.e. semaglutide, should be used? Yeah, you know, people are starting to call semaglutide colloquially the bariatric surgery drug. It doesn't quite achieve the same weight loss efficacy, but those sort of 12-kilogram placebo-adjusted weight loss outcomes are pretty impressive. So going head-to-head between bariatric surgery and semaglutide for cardiovascular endpoints, I think is a very valid study design at this point.
Excellent. Thank you again so much, Amanda, for spending the morning with us. This was fantastic, and we hope to host you in person in New Haven sometime in the future. And thank you, everyone. We'll see you again next week.
Thank you. Really appreciate
Bye.
it. Lovely seeing you all.